Good afternoon, everyone. I would like to thank the organisers for the opportunity to speak at AGW this year. So as we all know, achalasia is a primary esophageal motor disorder, and the etiology remains unknown. However, what we do know is that it is due to a degeneration of the myenteric plexus, and this leads to impaired relaxation of the lower esophageal sphincter and a loss of organised peristalsis in the esophageal body. The current reported incidence seems to be growing and is now thought to be around 3 per 100,000 patients. So what are the symptoms? It commonly presents with dysphagia, regurgitation, chest pain, weight loss and heartburn. And as you know, these symptoms overlap with reflux. So in patients who are presenting with reflux but the diagnosis is not clear, we need to think about dysmotility problems as well. Of course, in terms of diagnosis, the first step is an endoscopy, and at endoscopy you may notice that there is salivary retention. There may even be pieces of food which are left behind in the esophagus. You may notice the esophagus is a bit dilated, it could be tortuous, and you may see some stasis changes in the esophageal mucosa. And most commonly you will note that passage of the endoscope is fairly tight through the gastroesophageal junction. In order to confirm the diagnosis, we need to obtain a high-resolution manometry, and please note that in terms of the diagnosis, we classify patients into type 1, 2 and 3, and this is important from an outcome perspective, but also the type 3 achalasia is a condition that involves the entire esophagus, and this impacts the outcomes for the patients depending on what treatment they obtain. So most of the standard treatments are targeted at disrupting the lower esophageal sphincter fibers. So Botox injection is an endoscopic procedure whereby we inject Botox into the 4 quadrants of the lower esophageal sphincter. Unfortunately, the clinical outcomes are short-lived and this is not a permanent solution for the patients. Pneumatic dilatation is another endoscopic procedure. In this situation, we pass a wire across the lower esophageal sphincter, and under fluoroscopy guidance, we place a dilatation balloon, inflate the balloon, which causes rupture of the lower esophageal sphincter. The pneumatic dilatation balloons come in 3 sizes, 30, 35 and 40 millimeter diameters, and generally we need to do multiple procedures to achieve a good clinical outcome for these patients. Laparoscopic helimyotomy is a surgical procedure performed by upper GI or cardiothoracic surgeons. In this situation, the surgeons access the lower esophageal sphincter and the cardia and the lower esophageal body in a transabdominal approach. And if you can see on the left-hand side of the image, the surgeon here has already splayed open the outer longitudinal and the circular muscle fibers of the esophagus, and exposed here is the esophageal body, specifically the mucosa of the esophagus. The clear fibers you can see on the side are the submucosal fibers, which have also been dissected away. All surgeons will also perform an anti-reflux fundoplication in patients who undergo helimyotomy. POEM is also an endoscopic procedure, and in this procedure we achieve a myotomy. POEM or peroral endoscopic myotomy is performed with a standard gastroscope. We create a submucosal bleb in the wall of the esophagus, perform an incision, and we maneuver the endoscope into the wall of the esophagus. We create a submucosal tunnel by injecting saline, which is usually stained with methylene blue or indigo carmine. We use knives to dissect and also split open the muscular fibers. The procedure can be performed at the level of the sphincter, and it can also be performed for the entire length of the esophagus, which is generally required for a good treatment outcome in patients with type 3 achalasia or other spastic esophageal disorders as well. At the end of the procedure, the incision is closed with standard endoscopic clips. Any vessels or bleeding seen during the procedure are all treated with coagulation forceps. So all these procedures, including POEM, have been around for many, many years now, and there is lots of data available in the literature. There have been lots of retrospective and prospective studies comparing different procedures and looking at the outcomes. Lots of societies have now published up-to-date guidelines on how to manage achalasia. The ACG published their guidelines in 2020. ASGE also published guidelines in 2020. ISDE, Diseases of the Esophagus, published guidelines in 2018. The Surgical Endoscopic Society has also published guidelines in 2021, and I've also co-authored these guidelines. And I think a nice article also to use is a personalised approach to achalasia. And personally, this is the guideline that I sort of use to have the chat with patients about how to manage their achalasia. So one of the landmark studies that has recently been published is a randomized controlled trial comparing endoscopic and surgical myotomy in patients with all types of achalasia, types 1, 2 and 3. This study commenced in 2012, back when I was a fellow, and I remember at the time trying to recruit patients for this study was quite difficult because a lot of patients wanted to go straight to the POEM arm and didn't want to go to the surgical arm. This is a multi-center study performed across Europe, and POEM operators all had at least 50 procedures under their belt before enrolling patients into the study. Laparoscopic helimyotomy operators had at least 20 procedures experience. Myotomy was performed at an 8 centimeter length for type 1 and 2, but in type 3 patients the myotomy length was tailored as a longer myotomy for their disease process. So, as I mentioned, there was a lot of difficulty recruiting patients for the study, but over a 3-year period they were able to randomise 112 and 109 patients in each arm. And as you can see in this slide, the POEM and helimyotomy success was pretty equivalent across all time periods. So beginning at 3-month follow-up all the way out to 24-month follow-up. This was a non-inferiority study. So this study shows that the clinical outcomes for a patient, whether they have a POEM or a helimyotomy in terms of resolution of their dysphagia symptoms, is equivalent. You will see that over time there is a lowering of the success rate, so you're getting from high 90s down to high 80s, and this is I feel it's a result of one of the issues with achalasia in that it is a relapsing remitting condition. So a lot of people talk about failed surgery or failed POEM, but we need to think about, is this a technical failure, or is this the patient coming back with the disease again? The other issue to be mindful of at the moment is reflux, and in this prospective RCT, there was a higher incidence of reflux earlier on in the POEM versus the helimyotomy group, but when you look out at 2 years' time, there wasn't really a significant difference in the overall reflux grades or the acid exposure across both groups. Another landmark study that has just been published in 2019 is the effect of POEM versus pneumatic dilatation in patients with achalasia. Again, this was a randomized control study, multi-center across Europe, USA, and Hong Kong. This study also included all types of patients, 1, 2, and 3. And in this study, patients were treatment naive. In the pneumatic dilatation arm, patients had a 30 millimeter dilatation, and then 2 weeks later, if there was no clinical response, they had another dilatation at 35 millimeter. If there was still no response, patients were taken up to 40 millimeter dilatation as well. Patients also were crossed over to the POEM arm at this stage if they still did not have a good clinical outcome from their pneumatic dilatation. Again, the reflux rate is a bit higher in the POEM versus the pneumatic dilatation, but you can see most importantly the overall treatment success rate is much higher in the POEM group. So you're looking at the 2-year follow-up data, which was their primary outcome, 92% versus 54% in the pneumatic dilatation arm, and even earlier on at 3-month follow-up, which is pretty soon after the patients had multiple dilatation procedures, treatment in the POEM arm is 98% versus 80% in the dilatation arm. There was a perforation in the pneumatic dilatation arm, and that was a perforation with a 30 millimeter balloon. So in both groups, there were patients who ended up having retreatment in long-term follow-up at 2 years, but you can see in the POEM arm there was 8% retreatment rate, whereas compared to 41% of patients in the pneumatic dilatation arm needed repeated treatment at 2 years. And again, as I mentioned, reflux is higher in the, or PPI use also specifically is higher in the POEM arm, but this is also consistent with the fact that they had a higher success rate in terms of dysphagia. Now, the Surgical Society guidelines is the only guidelines published at the moment which also incorporate the 2 randomized controlled studies in terms of their recommendations in their guidelines. And the surgical guidelines addressed both adults and children with achalasia, not adults alone. So, to summarize the guidelines, basically the question is, should patients have POEM or pneumatic dilatation for both adults and children with achalasia? And the guidelines recommend POEM over pneumatic dilatation as a strong recommendation. In terms of the question of should patients have a POEM or a helimyotomy for adults and children with achalasia, in patients with type 3 achalasia, where the disease process involves the entire length of the esophagus, we know that pneumatic dilatation only targets the lower esophageal sphincter. Laparoscopic helimyotomy also can only target the lower esophageal sphincter from a technical perspective, given their access is transabdominally. They cannot achieve a long myotomy. POEM is the only procedure that can achieve a long myotomy, and this is what is needed for clinical success in patients with type 3 achalasia. In terms of type 1 or 2 achalasia, the recommendations are patients can have either a POEM or a helimyotomy, and this is probably an approach you can discuss with the patient depending on the patient's preference, and I think more importantly the skill set that's available for the surgeon or the POEM operator in your centre or your area. What's also very important to note is that in these guidelines, it was a combination of surgeons and gastroenterologists who worked on the guidelines, and there was also patient representatives who contributed to the recommendations and decision-making process in this particular guideline. Now, the one question that is always asked of me is how many is enough till you become very good at POEM? And I think this is an individual outcome issue. Most people become good at 70 cases, and this is probably the largest study that shows that you become technically very good at a minimum of at least 100 cases before your clinical failure, your technical failure, and adverse event rates drop down to as close as 0 as possible. So how should we approach our patient with achalasia? And this is the way I do it. I talk to them about all 3 procedure options. There is a bit of a bias in the fact that when patients are coming to see me, they've already decided they want a POEM, but I still go through this decision-making process with them so that they understand why they're making this decision and the benefits and downsides to each of the treatment options available to them. So pneumatic dilatation is an outpatient procedure, which is clearly an advantage, but multiple procedures are required. And we know now from the latest data that pneumatic dilatation has a significantly lower success rate compared to myotomy. POEM requires an overnight stay, but this is a single-step procedure which will achieve a good outcome for the patient. Helimyotomy is also a single-step procedure which will achieve a good outcome for the patient, and there is a short to medium-term inpatient stay involved. In terms of reflux, this is a question that all patients will ask, what about my reflux? And I always say to them, look, the trade-off for being able to swallow is that you are going to get some reflux. So you will see from all the data I've presented that all 3 procedures, POEM, pneumatic dilatation, and helimyotomy, are associated with reflux post-procedure. And of course, you disrupt the esophageal sphincter. You have to do that for the patient to be able to swallow, and as a result, some reflux will occur. In a helimyotomy, patients do have an anti-reflux procedure, but unfortunately, this can also be associated with prolonged dysphagia from the wrap being too tight or swelling edema around the wrap site. The reflux rate is probably about 20% in pneumatic dilatation and between 30 to 35% in POEM and 20 to 30% in helimyotomy in the first instance. However, long-term data shows, long-term follow-up shows that this all equalizes in the long term. The most important thing is majority of all reflux is easily controlled with a PPI. In terms of patients who have type 3 achalasia, this is a very easy discussion. There is no role for pneumatic dilatation and there is no role for helimyotomy, as the success rates are less than 50%, and this patient should be having a POEM. We also should be discussing risks with the patient. So in terms of pneumatic dilatation, there is a risk of perforation with each procedure. In POEM, there are numerous risks. However, all the data shows the risks are quite minimum, and most of these complications are managed endoscopically during the procedure itself. For helemotomy, there is a risk of the fundoplication being too tight. There are also surgical risks, wound complications, etc. And I think most importantly, in a surgical myotomy, the patients need to be aware that if the fundoplication is too tight, then they end up at square one. So I think over the years we've seen a pretty clear evolution going from the scalpel to the scope. We've seen this with cholecystectomy, colonic polyps, GI bleeding, early esophageal, early gastric, early colonic cancers. Pancreatic fluid collections are all managed endoscopically. With achalasia myotomy as well, there is a huge shift and a change to the preference for achalasia myotomy, not just from the literature itself, but certainly we're seeing this from patient choices as well. So to summarize, the incidence of achalasia appears to be increasing, and this may just be to raised awareness, but we're certainly seeing a higher incidence rate in the community. And please remember, this is a relapsing disease, so patients who have had achalasia, had a treatment, they come back with symptoms, they should be considered for repeat treatment. I haven't spoken about that specifically in my talk today, but we can discuss in question time if need be. High-resolution manometry is diagnostic, and it's important to determine the outcomes for the patients depending on if they have type 1, 2 or 3. Myotomy is superior to dilatation. Specifically for type 3 patients, POEM is superior to helemyotomy and pneumatic dilatation. In type 1 and 2 achalasia, pneumatic dilatation is inferior to POEM, and as you know, it requires multiple procedures. POEM and helemyotomy are equivalent, and the choice really depends on the expertise available in your area or to your patient, the experience and volume of the operators. As I always say to the patients, the trade-off for being able to swallow is reflux. No matter what procedure you have for your achalasia, you are going to have some degree of reflux. However, we know that in the long run, the reflux risk equalizes across all three, and hopefully you'll be around to listen to the next speaker's talk, and I think the endoscopic anti-reflux therapies are going to have a huge role to play in these patients who are preferring a minimally invasive endoscopic approach to their problem. And another issue that I didn't really discuss in the talk, but we do need to think about surveillance in these patients as well. Achalasia itself has a risk of cancer, and then knowing that all these patients do have reflux post whatever procedure they have, we should be monitoring them for reflux-related complications as well. Thank you for your attention.